I'm a consultant for a company called Benvenue, and a lot of material is not FDA approved. It's CE approved for Europe, but a lot of them are not used in the US. This is my hospital, which is a university hospital in Athens of 800 beds, and we perform many of those and all of those procedures over there. What about skeletal metastases? Metastases of the skeleton represents the most common type of malignant bone tumor. Any neoplasm can give you a metastasis on the musculoskeletal system. General population carcinoma of the breast, prostate, and lung. Males carcinoma of the breast and females carcinoma, males carcinoma for prostate and females carcinoma of the breast. Bone disease can become very, very painful, especially in case of lytic lesions. You have different possible treatments, which include surgery, embolization, chemotherapy, osteoplasty, radiotherapy, and palliative analgesics. And I'll try to put all of those together to give you a better idea. The events that you have to follow is that the neoplastic cells must separate from the primary tumor, gain access to the blood path, survive the transport, attach to the endothelium, and then exit the vessel and find a way to supply themselves in order to create a metastasis. This is a very complicated procedure, but it shows the resiliency of the tumor cells which are able to do that. The possible treatment, as I said, is surgery, chemotherapy, radiotherapy, embolization, osteoplasty, which is bone augmentation, and bone ablation, or a combination of those. Starting from the simple one, and the one that most patients are having, is radiotherapy, which is external beam radiation. And although used frequently, one thing we should know is that 70% of the patients will have only a limited time of pain relief. This also can provoke neural damage and also can induce osteonecrosis, which means that you can have the radiotherapy and then you have a fracture from the radiotherapy. So why do we do the injection of PMMA and the bone augmentation and the injection of cement? Well, we do it for palliative reasons. First of all, because you stabilize the fracture. You stabilize the fracture, which is a non-union fracture, or you combine it with surgery. On the other hand, the cement has an exothermic reaction, and then you can go for local regional tumor control if you add ablation to it or radiotherapy. The thermal effect of cement is very well known and established for many years, and we know that everything that above 50 degrees has a percentage of necrosis of the cell. So we use that temperature effect in order to kill the tumor cells with the cement. There are different papers showing that thermal necrosis or that effect of the cement on bone. This is a cadaveric sample of a patient who had adenocarcinoma, and you can see where the cement was, there is no tumor. The tumor is only in the periphery. Here is a bigger image. It's approximately 1 centimeter away from the cement. So actually we know that cement and tumor cells do not live very well close together. This is another effect of a cementation of a femoral head. You can see the yellow bone marrow, which is normal marrow, and the tumor is always away from the areas of cement. Another example of a case with 3 different treatments. The patient had an anterior fixation. He had radiotherapy, and he had a vertebroplasty. Only the vertebroplasty did not have a new tumor. You have tumor in the area of the fixation, and you have tumor in the area of the radiotherapy. Of course, this is renal cell carcinoma, but it shows, and it's only one case, but it shows you that cement is very resilient to tumor. There's another case, for example, with a patient who had all the treatments. He had radiotherapy, and you can see the effect of radiotherapy, and then he had an osteonecrosis due to the radiotherapy. Then he had a decompression and a laminectomy, and then what? If you do not do anything, then the patient will end up paralyzed. You have to do something to support the structure. If you go a posterior fixation, it's a long procedure for the patient with a limited lifespan. So what we did a 3 levels vertebroplasty and stabilized those 3 levels. Again, this is the image of the CT post-treatment and the image pre-treatment. And you can see that this is an elegant way to give the support you want. The patient leaves the next day from the hospital in a very good state without pain. Again, another patient with breast mets. He had a vertebroplasty in 1 level, then he had a new metastasis in the level above, and an osteonecrotic fracture after the radiation. So in this case, we treated the other 2 levels in the same way, the needle placement, and you can see the cement injection that fills the necrotic area of the vertebral body. And this is the AP plan. What about pain relief? This is a patient with an HCC metastasis. He has survived his HCC, and he has a big lytic lesion, has completely destroyed that vertebral body. If you go for surgery, then you have to replace all that vertebral body with an anterior and posterior fixation. It's a quite complicated procedure surgically. And the patient possibility of lifespan is 6 months. You need to do something for him that will help him live these 6 months without pain. Opioids is a solution, but it diminishes the quality of life of the patient since they are very heavy drugs. So you can go inside, puncture, and inject your cement inside that vertebral body and stabilize that lesion. You talked about biopsy for renal cell carcinoma, for RFA. It's the same thing here. You can use coaxial systems to take bone biopsies that will show whether after the radiotherapy there is vital tumor in the area, and you can use these coaxial systems in order to take good samples. If you do not do biopsy, sometimes you might risk with this example. This is a patient that had a kyphoplasty, and you can see the cement right here. They thought it was an osteoporotic fracture. Actually, it was a metastatic lesion, and it ended up blocking the tumor, the whole canal. And the patient ended up with a posterior fixation, but he was already too late and too paralyzed. So you need the biopsy actually prior in order to verify that you have a lesion in the area, especially in bone. If you have a tumor that is coming inside the lesion, inside the canal, and this is not a paraplegic patient, but a patient who has a paraparesis, then you can do a combined treatment. You can do, as interventional radiologist, the stabilization and the pedicle stabilization, and a collaborator, a neurosurgeon, can come and do a laminectomy posterior and decompress only locally. By doing this decompression, the staging is faster, the patient is mobilized faster, and he can go away from the hospital in 24 hours instead of having a posterior fixation, which is a longer procedure. Again, you can help colleagues like orthopedic surgeon. This is a patient that had a posterior fixation but had tumor, and what happened is that the screw became lax because of the tumor inside it. So either he had to do a revision. Instead of doing a revision, we went and stabilized with cement around that screw. And in that way, the patient was able to not to have a new operation for the posterior fixation. So you can combine techniques and help also other specialties. You can inject the cement in specific locations. For example, you have a lytic lesion which comes exactly on the pedicle, and you can fill exactly that area of the pedicle like you would do a dental filling. What about blastic lesions? For blastic lesions, you cannot inject cement by itself. You need some other techniques to create holes inside that very dense bone. You can see here the area of the dense bone with the osteoblastic lesion of the prostate. And you have different ablation systems that can create holes in that bone. And unfortunately, the video is not playing. But here you can create holes, and this is the device inside the bone, followed then by the cement injection. And you can see that you can inject cement inside the osteoblastic area. Again, this is the same thing, a patient with multiple blastic lesions, the needle in place, followed by the ablation and the hole-making mechanism. This is contrast injection, showing that we can inject something, followed by cement. Here is the MRI prior to the treatment. Here's the CT scan superimposed post-treatment. You can see we were able exactly to fill the area of the metastatic lesion. When the tumor comes across and comes outside the plane, that might be scary because you might have a leakage there. And if the cement leaks around, then you might have a problem with the nerve and create a severe neurological deficit. So you can do different tricks, and different tricks is just putting a needle inside the foramen and injecting cold saline in order to protect the nerve, and then inject the cement. And this is the cement injection inside the tumor. At the same time, we're cooling down the nerve root by continuous injection of saline. This is the reconstruction. There is some cement inside the foramen, but we protected the nerve by cooling that nerve continuously down. You can do even more difficult cases, transoral, which is quite easily to see the vertebral body through the mouth, and you go through the mouth inside the bone and inject the cement in a lytic area. And this is the reconstruction of C2 vertebral body and the dents by cement injection. This is the CT showing the cement reconstruction. Again, another case with a similar effect. And again, this third case with an anterior approach. The reconstruction can be done in very lytic vertebral bodies. Of course, I would not suggest this for you to be your first case, but this shows you where you can push the method if you train and your ability is developed in order to do these cases. Of course, you need good imaging. And if you watch the dates, this patient was done a few years back, and in 2008, still that vertebral body held the tumor in place without any expansion. 2012, you have some compression, but still the patient is standing alive 4 years later. The problem is that cement cannot hold all forces, so you will need other materials. What other materials would you need? Well, now we have metallic implants and metallic stents that you can use inside bone. And this is that kind of metallic stents that you can inject inside bone. Or you have PEEK material, which is a very plastic material, which is very hard and can support the vertebral body by itself even without cement. And you can put that PEEK cage inside the bone and inject it afterwards with cement. Again, a fracture, split fracture, and in this split fracture, which is called an A2 fracture, you can develop and put that cage and then inject the cement. And this is the cage inside the bone. This all can be done percutaneously. What about peripheral lesions? Peripheral lesions, patient with leiomyosarcoma metastatic, we treated one area, he has a second metastasis, we treat the second metastasis and stabilize the second area. What about osteonecrotic fracture? This is an osteonecrotic fracture of the pelvis for a patient that had radiotherapy in the pelvis for a ureteric carcinoma. And this is the support that we did of the fracture of the pelvis. This was a very painful condition for a lady that could not walk. Or you can do femoral head reconstruction, and it's very simple to place 2 needles and inject some cement inside the femoral head. This, again, a pelvis reconstruction. You can see the cement inside the pelvis and reconstruction of the area. Now, you can go for pain relief and you can go for local regional tumor control, which means that you want to control the local metastases. How are you going to do that? With all the combination treatments. For example, you can start with a chemoembolization in the area, and you can see the area we're embolizing, followed by a microwave ablation of the soft part tissues of the tumor, followed by the cement injection inside the bone. So now we're using all different interventional techniques in order to match all of them and be able to control the tumor locally. You can go for long bones when you have vertical forces, like in this knee, for example, where we injected one part of the knee. And you can see the reconstruction with the cement, and this can be done percutaneously. If you inject cement in long bones, the problem is that it will fracture. Cement will not hold anything that have torsion forces. It needs to be compressive forces. So in this case, for example, they injected cement, it ended up with a prosthesis. What you need in this case is once you place, you need some metallic support, and this metallic support, like a stent or a metallic mesh, will give you the strength that you will need for the bone to hold. And these are these kinds of reconstructions that you can do. This has already been published, and this work, it's not done by orthopedic surgeons. If you see the paper, this is from Thierry Deber's team. They are interventional radiologists that now are putting screws inside bone. So if we compare it to the vascular world and the vascular interventionalists, the bone work now is the 80s of the interventional radiologists. We have minimal invasive treatments for bone that did not exist before. You can do multiple levels, and this is multiple myeloma with multiple levels of injection of cement for multiple lesions, painful lesions that you want to stabilize. And there are papers showing that the efficacy is very good, and you have not more complications for multiple level treatments. Now, of course, we have to talk also for radiofrequency. And radiofrequency has shown that has a very good effect for tumor treatment. And you can treat, for example, small lesions like these little rib lesions that you have here from HCC. Again, here you can do an RF. Or a bigger lesion from a metastatic colorectal carcinoma from the scapula. Or again, you can do a combination treatment. You can see the lesion here, which is in the periphery of the bone, where first we RF'd it, and then we cemented it. Or you can do other ablation techniques like cryotherapy. And this is a big lesion from a plasmatocytoma with cryoprobes placed in the area. Be careful when you are ablating big lesions, the creatine kinase might go up, so you might have a kidney issue. Be very careful to monitor the creatine kinase for bigger ablations of soft tissue. And you can see here the formation of the cryo and the ablation zone of the ice ball formation. This is the PET scan, the scintigraphy before, and this is the image after. You can see that most of the tumor has gone away. And we have other treatments like microwave treatments that you can ablate also. We're ablating here a spinous process, a painful area. We're just placing the cryoprobe, the microwave probe directly inside the spinous process and destroying that. Or bigger soft tissue areas like in this big lytic lesion, and you can see how microwave can do big destruction. So if you have a big soft tissue lesion without any real nerve problem close by, you can use microwave like a big weapon to destroy and ablate a big portion, a big chunk of that soft tissue. Of course, when you're doing those kind of treatments and any IR treatments, you have to be clinician. You have to know what you're doing in your patient, not just the act, but see the patient and have a clinical and significant role in the treatment of the patient. This is a patient sent to us from the orthopedic team. You can see that he has multiple metastases in the spine, and we're now sending us this patient to treat for a vertebroplasty and RF for those bone treatments. But we examine the patient and we verify that actually the pain is not associated in the areas of those lesions. And if you see, you can just notice that something is happening in the side here, in the area. So we ask a new CT scan. So now the radiologist is asking the clinician to prescribe new imaging. And we do new imaging, and actually what's painful is a big lytic rib lesion. So in this big lytic rib lesion, which is painful, what do? We place a microwave probe with some ice ball on top to protect the skin, and we ablate that area. A new technology that's coming in also in bone is MR-focused ultrasound. There are new algorithms now that will allow the ablation of bone. It was more difficult in the beginning, but now they are able to create a Novin effect inside the bone and use the MR-focused ultrasound for that. And it will play surely a significant role in the future. So osteoplasty and RF, radiofrequency or any kind of ablation seems to show efficacy, but does not show superiority to cement itself. There is a risk of osteonecrosis in any kind of ablation procedure. So also there is an increased risk to create a neurological damage, especially if you're close to a neural structure. Be very careful with RF because you risk to ablate the nerve too. What else do we have instead of cement? There are new combinations coming up, and these combinations are published now. You have combination of cement with radiotherapy and see how is the effect, additive effect of radiotherapy on cement. You have cement and chemotherapy. How are you going to use that with different chemotherapy products which you can embed inside the cement and they can be liberated by the cement itself? You can have ferrous oxide activation and radioisotopes, again, involved with different polymers inside bone. The future of treatment of these all kinds of treatments that we talk is to pass from palliation, which we usually use it for bone, to pass to local regional tumor control, which means that we find the more important metastases, the one which is painful, the one which is unstable, we go for them, we treat them, and they do not come. Treatments which are not invasive are ineffective. Then you have to choose whether your site you're going to treat is a weight-bearing area or a non-weight-bearing area. If you're in a weight-bearing area, then you have to go for a stabilization. And RF alone will not give you that stabilization. You need some material inside there to replace the bone. If you're going for a non-weight-bearing area, like a soft tissue mass, then you can go for ablation. You ablate that zone. If you want to go for tumor control, and whether it's a weight-bearing area or a non-weight-bearing area, you can use both ablation and stabilization in combination. And at the same time, we have to find the role of embolization, perhaps chemoembolization more in the future inside those lesions. There's also a lot of talk whether the radioembolization will also play a role in the system. Now, all of this has to play a big question about the performance status of the patient, about the patient compliance to have all these procedures, about the analgesic drugs he's having, and about the surgery role. In conclusion, osteoplasty for bone lesions is an important tool for pain. The control of volume and the consistency of cement is very important during those injections. Osteoplasty is an embolization procedure. You put one little tiny bit of cement after another like you would do an embolization. The types of treatments should be adapted to the type of lesion you have in front of you. We haven't seen any tumor displacement, and the patient can live 24 hours after the treatment. It can be accompanied by other techniques, and good planning, and of course, good material for visualization is very, very important. Ablation also is an important tool for patients in pain, and all the energy deposition techniques can stand alone, but in non-weight-bearing areas. The type of treatment should be adapted to the lesion that we have to treat, and it should be accompanied by osteoplasty in weight-bearing areas. Of course, again, good planning and good visualization is very important. Thank you.